Hi class, we are going to discuss respiratory system today, it will be, our PowerPoint is going to be on upper respiratory tract and lower respiratory tract. So this is chapter number 53, 54, and 55 from your book, the Quartz book. And let me do our screen share. And we are going to look at PowerPoint from chapter 53. Okay, so if you look here, so from the beginning, introduction to respiratory system. So respiratory system has upper respiratory tract and the lower respiratory tract. What are the functions of respiratory tract? It brings oxygen into the body and allows for exchange of gases and expels carbon dioxide and other waste products. The respiratory tract has, if you look at this picture, it has nasal cavity, larynx, pharynx, trachea, and bronchia. Then we have on the bottom, these are just the cells, and then all these bronchial tree turns into, it becomes the small sacs is called bronchial tree, right? And then if we look over here, these are just names of the structures. From the nose, there's sinuses on the sides of our cheeks, then pharynx in our neck, and then larynx in our neck, and then it extends to trachea, and then bronchi in the lungs. There are hair filters, that filters the air, also like hair-like structures inside the nasal tract. It's called cilia. Cilia moves the trapped material towards the throat for swallowing. The blood supply close to the surface warms the air and adds humidity to improve the gas movement and gas exchange. The cough and the sneeze reflex clears the airway. So cough reflex, what is a cough reflex? So let's say if you, there was something irritating that came to the throat, and then the body has this cough reflex that it will cough it out. It will basically, there is a reflex that will help those whatever foreign materials to be coughed out. So cough reflex is the walls of trachea conducting bronchi are highly sensitive to irritation. When receptors in the walls are stimulated, the central nervous system reflex is initiated. So cough causes air to be pushed through the bronchial tree under the tremendous pressure, clearing the airway of the foreign irritant. And then sneeze reflex. What's a sneeze reflex? It is initiated by receptors in the nasal cavity. So foreign materials which your body doesn't like, or it's irritating to the nose, and it causes that sneeze reflex. So cough and sneeze reflex, mostly coughing reflex, is to expel things out which our body just doesn't like. Cilia, if you know, cilias are like fine hair-like structures underneath in the tract nasal passage, and the surface cells and the mucous cells are underneath. The layers of the bronchial tubes, are basically made of cartilage, some muscle, and some epithelial cells. Now, the purpose of cough and sneeze reflex is to clear the airway. True. Lower respiratory tract. So, lower respiratory tract is composed of small bronchioles and alveoli, considered the functional unit of the lungs. And gas exchange occurs at alveoli, also called as ventilation. The components of respiratory membrane and gas exchange. So gas exchange occurs at alveolar level. The alveolar sacs holds the gas, allowing the needed oxygen to diffuse across the respiratory membrane. It consists of the following: capillary endothelium, capillary basement membrane, interstitial space, alveolar basement membrane, alveolar epithelium, and surfactant layer. Now if you look at this, and this is a very nice picture that tells you when air is coming in and it diffuses in the alveolar wall, and goes inside the capillary. This is the blood supply. This is a capillary bed underneath the lung tissue. And the RBC, the red blood cells, absorbs all that oxygen, and it releases the CO2, carbon dioxide. And so we inhale, the oxygen goes in, and when we exhale, the carbon dioxide moves out. The process of respiration. So process of respiration is controlled through the medulla of central nervous system. It depends on the balance between sympathetic and parasympathetic nervous system, and it depends on the functioning of the muscular system. So for parasympathetic nervous system, it helps the diaphragm contract and in inspiration. And vagal stimulation leads to bronchial constriction. Sympathetic stimulation leads to increased rate and depth of respiration and dilatation of bronchi to allow free flow of air through the system. So whenever our sympathetic nervous system, which is fight and flight response, that is activated, a person is able to breathe. There's a little bit of bronchial dilation, and they're able to breathe better, just in more relaxed mode. So that is a sympathetic nervous system stimulation. Upper respiratory tract conditions. Upper respiratory tract conditions could be some abnormalities in upper respiratory tract. Could be rhinitis, sinusitis, pharyngitis, and laryngitis. Now, sympathetic stimulation of respiratory system leads to what? Decreased respiratory rate, decreased depth of respiration, increased respiratory rate, or increased perfusion of the lungs. Increased respiratory rate. Sympathetic nervous system leads to increased rate and depth of respiration and dilation of bronchi to allow free flow of air through the system. Now, lower respiratory tract conditions. Lower respiratory tract conditions are atelectasis, pneumonia, bronchitis, bronchiectasis, COPD, cystic fibrosis, and respiratory distress syndrome. So these are just fancy names for. Now, what are those? Atelectasis is the ball-like structure at the end of the lungs. It's called alveoli. When it collapses, the ball basically collapses. Because not enough surfactant, which is the layer that keeps it open. That condition is called atelectasis. The result of outside pressure against the alveoli, and most commonly occur as a result of blockage of the airway. Pneumonia. Pneumonia is definition is inflammation of lungs. As we know, there are times when we talk about, oh, you know what, that person has pneumonia. That means like they have inflammation and infection in the lungs. Causes could be bacterial, viral, and aspiration of foreign substances into the lower respiratory tract. And manifestation includes swelling, engorgement, exudation of protective sera. Bronchitis. Bronchitis is inflammation of the lower part of the lungs. And also, basically those pipes that cause that air to flow into the lungs are bronchi. And if they get inflamed, that condition is called inflammation, and that condition is called bronchitis. Bronchiectasis. What is bronchiectasis? Chronic disease characterized by dilatation of bronchial tree, chronic infection, inflammation of bronchial passages. It causes often underlying medical condition that makes them more susceptible to infections. Signs and symptoms: acute infection, fever, malaise, myalgia, arthralgia, and a purulent productive cough. Chronic obstructive diseases. Some obstructive diseases are asthma, COPD, cystic fibrosis, and respiratory distress syndrome. So asthma, what happens in asthma is that condition causes those bronchial tract to squeeze more. They become tightened up because of severe allergies. And that condition is called bronchospasm. Bronchospasm is like when the pipeline that squeezes tight because there's like an allergen, like a pollen allergy, that could cause this airways to squeeze. That is called bronchospasm. Distended and alveoli versus normal alveoli. So look, this is like a balloon-like structure at the end of the lung, and that's how they look like. So this is a bronchial tract, and then there's alveoli at the end. And their inner surfaces are surfactant, full of surfactant, to keep them open. And then there's times when they could collapse because of not enough conditions in the lungs, such as infection, inflammation, pneumonia, that could cause them to collapse. Chronic obstructive pulmonary disease, what is that? Permanent and chronic obstruction of airway. It causes often related to cigarette smoking, emphysema, chronic bronchitis. Manifestation include airflow obstruction on expiration, overinflated lungs, and poor gas exchange. Cystic fibrosis, this is another condition where all those ducts are blocked. Those ducts that are, those cilia, they're not able to move because of copious amount of thick secretions in the lungs. And it could be, this is a hereditary disorder. So cystic fibrosis is a condition when we know that a person is not able to cough and their ducts don't move, and then this is a hereditary disorder. Respiratory distress syndrome. Respiratory distress syndrome is when a person is not able to breathe at all. It's with shortness of breath, difficulty breathing. There could be multiple underlying causes. Underlying causes could be infections, inflammation, or there's tons of different disorders that could happen to cause respiratory distress syndrome, bleeding or blunt trauma, anything. But respiratory distress means a person is not able to breathe. We need to intubate them. They're having shortness of breath, difficulty breathing. We need to do something about it. So that's basically a grave syndrome. An elderly Native American woman has tested positive for tuberculosis. The woman refers to TB by another name. What is that? What is that name? Bronchiectasis, emphysema, COPD, or consumption? So consumption, TB is a bacterial infection once known as consumption. This disease has been responsible for many respiratory deaths through centuries. So that is TB. TB, when a person has TB or tuberculosis, we know that they feel very not unhealthy, pretty much. It's a condition where patients will feel they're having pneumonia, inflammation in the lung tissue, and it would cause coughing. There are times when patients with TB will say, I was having blood in my sputum. They cough and they cough out blood. So all of that. They are all related with inflammation in the lung tissue and infection in the lung tissue. So this was just a little bit of anatomy, and now let's talk about the upper respiratory disorders. So let's look at PowerPoint from chapter 54. Okay. Now we're going to talk about certain medications that will help in the treatment of upper respiratory tract disorders. Okay. So one is antitussive. The first one is antitussive. They block the cough reflex. So whenever we have, let's say, an allergy, you went to the fields and then now you're coughing, sneezing, and then you feel kind of stuffy in your nose. That condition is called rhinitis because of allergy, or because of some kind of your body is not liking certain allergies or certain things from the field, right? So now it could cause coughing, irritation, redness in their eyes. So sometimes we have to give patients antihistamines such as Benadryl for allergies. Sometimes we have to give them antitussives. Antitussives are cough reflex blockers, so they will block the cough reflex. And then decongestants, something to decongest. So if someone's having congestion in their chest, we give them something called as decongestants. Such as mucomyst, such as there's tons of different kinds. Antihistamines are to block the histamine. Histamine is the one that causes allergies. Antihistamine is, an example is Benadryl. Expectorant, when they have very thick secretions and they need to cough them out, we give them something called as expectorant that will help them to cough out those secretions. Mucolytics. What is mucolytics? Something that will liquefy those thick secretions. So that will break that mucus. Or lytics means break down, and muco means mucus. So something that will liquefy those secretions. So those are called mucolytics. Now they all work in different areas. We're going to go one by one. Antitussives. So some examples of antitussives are they suppress the cough reflex. Some examples are benzoate, codeine, hydrocodone, dextromorphin. Actions, what do? They will suppress the cough reflex in the brain, and they will slow down the coughing. When we have a lot of cough, constant coughing, it irritates the, it's very irritating, constant cough, and it causes bronchospasms, and so we give the antitussive to reduce the amount of coughing. It controls the non-productive. What is non-productive? When there's not a lot of sputum, it's kind of dry cough, so it will slow it down. Rapidly absorbed, metabolized in liver, and excreted in the urine. Contraindications. What are contraindications? Patients who need to cough to maintain the airway, we don't need to give it to them. Patient who has head injury and they're not able to breathe anyway, so if we give them cough medication, where we don't want to depress the system if it's already depressed, as simple as that. Cautious, if a person has allergy, we don't give it to them. Adverse effects. It could cause drying effect on the mucous membrane. It could cause CNS, central nervous system, adverse effects, and GI upset. Drug-to-drug interactions, we don't give it with MAOI inhibitors, MAO inhibitors. So monoamino oxidase inhibitors. Nursing consideration for antitussives. Assess, always check for history and physical examination and history of allergies. Then check for temperature, respiration, adventitious sounds, orientation, and affect. Dextromorphin, there's control of non-productive cough. It depresses the cough center in the medulla to control cough and spasms. And then adverse effects could be dizziness, respiratory depression, and dry mouth. Nasal decongestant, something to decongest the nasal tract. What are those? Metazoline. Phenylephrine is the one which is very commonly used. So I would just say phenylephrine, tetrahydrozoline, and xylometazoline. Actions, what are the actions? They will, they're sympathomimetics. They will increase the sympathetic nervous system responses, affect sympathetic nervous system to cause vasodilation, causes less inflammation of the nasal membrane. Indications, it is to relieve the discomfort of the nasal congestion that accompanies the common cold, sinusitis, and allergic rhinitis. Pharmacokinetics, generally not absorbed systematically, and then any proportion of these topical decongestants that is absorbed is metabolized in liver and excreted in the urine. Contraindications, lesions or erosions in the mucous membrane. Cautious, any conditions that might be exacerbated by sympathetic activity. Adverse effects are local stinging and burning, rebound congestion, sympathomimetic effects. Drug-to-drug interactions, cyclopropane and halothane. Assess, whenever you give medication to your patient, you want to know what is the history and physical. You want to know what they're allergic to the patient, to the medication, yes or no. Do they have baseline conditions such as glaucoma, hypertension, diabetes, thyroid disease, coronary disease, prostate problems, orientation and reflexes. You want to know the vital signs, cardiac status, respiratory and adventitious lung sounds, nasal mucous membranes, and urinary status. One example is tetrahydrozoline. Antitussive agents should be used with caution with patients who have history of addiction. Yes. Why? Because they might have some depressing effect. So if they're already taking something to depress their respiratory system and they add on an antitussive, so it might just double the effect. Oral decongestants decrease nasal congestion related to common cold, sinusitis, allergic rhinitis. Pseudoephedrine. Pseudoephedrine is one of the examples. Oral decongestants they shrink the nasal mucous membrane by stimulating the alpha adrenergic receptors in the nasal mucous membrane. Indications, promotions of drainage in sinuses and improving airflow. Pharmacokinetics, well absorbed, widely distributed in the body, metabolized in liver, primarily excreted in urine. Oral decongestants, they're contraindicated in any conditions that might be exacerbated by sympathetic activity. Adverse effects, rebound congestion, sympathetic effects, Drug-to-drug interaction, we just have to make sure that if we're taking oral over-the-counter medications, they should not have pseudoephedrines in it. So it'll be like doubling the effects. Assess. What do you check? You always check for history, physical, you check for allergies, you check for pregnancy, lactation, hypertension, CAD, hyperthyroidism, diabetes mellitus, prostate enlargement, orientation, reflexes, affect, vital signs, and any lung conditions. Okay, pseudoephedrine is a very strong nasal decongestion. We give it for common cold, hay fever, sinusitis, any sinus drainage. What does it do? It causes sympathetic effects, which is bronchodilation, slowing down of the person's able to breathe better with them. Adverse effects could include anxiety, restlessness, headache, dizziness, drowsiness, vision changes, seizures, hypertension, arrhythmia, pallor, nausea, vomiting, urinary retention, and respiratory difficulty. Topical nasal steroid decongestants. Some steroids can be very strong in when a person's feeling very congested, such as beclomethasone, very commonly used flucortisone, then triamicolone. Those three are very commonly used. So they come in combination sometimes with different other medications. What do they do? All steroids are anti-inflammatory. Remember, those three functions of steroids are anti-inflammatory, immunosuppressants, and they are hyperglycemics. They increase the blood sugars. So anti-inflammatory, they will relieve the inflammation. Exact mechanism of action is not known. Indication includes seasonal allergic rhinitis, inflammation over removal of nasal polyps, and generally not absorbed systemically. Contraindications: with acute infections, with active infections, you don't give it to them because they will cause severe. They are immunosuppressants. Steroids are immunosuppressants. They will flare up infection. Adverse effects could be local burning, irritation, stinging, dryness of mucosa, and headache. Suppression of healing, they slow down because they are immunosuppressants, and they slow down the process of healing. Assess. Check for history and physical examination and known allergies, nasal mucosa, respirations, adventitious sounds, and temperature. Now, fluconide, here's an example of fluconide, and it could be given for allergic rhinitis, which is inflammation. Rhinitis is inflammation of nose. Actions: anti-inflammatory actions that results from ability to produce direct local effects that block the many of the complex reactions. Okay. Antihistamines. Other antihistamines are, remember Benadryl. We were talking about Benadryl. When a person has severe allergies, we have to give them something to reduce that histamine. So some of the other examples are bromophenyramine, also chlorphenyramine. Benadryl is another one. Selective. What do? They selectively block the effect of histamine. So basically, they will block the effect of histamine, not allowing a lot of inflammation and inflammatory responses to slow down. Anticholinergic and antipruritic effects. Antipruritic means it doesn't allow as much allergy or itchiness. Indications: seasonal and perennial allergy rhinitis, allergic conjunctivitis, uncomplicated urticaria, and angioedema. What is angioedema? Swelling in the neck. A person's not able to breathe very well. It's a form of severe allergy. Pharmacokinetics means a medication could be well absorbed, metabolized in liver, excreted in the urine and feces, and contraindicated in pregnancy and lactation. Cautious. We have to be real cautious when a person has kidneys and renal impairment. History of arrhythmias. Adverse effects include drowsiness and sedation. Anticholinergic effects. Drug-to-drug interaction is based on the drugs. Nursing consideration: I would always check for allergies, history and physical, pregnancy, lactation status, skin, orientation, affect and reflexes, respirations, adventitious lung sounds, and appropriate lab values. Diphenhydramine, and that is also called as Benadryl. It is usually, how many times we use it for allergies? Multiple times. We want to make sure it could be given for severe allergies such as angioedema, urticaria. And then actions could be to completely block the effects of histamine 1, and also adverse effect could be drowsiness, sedation, dizziness. When we take Benadryl, it's a good idea to sleep, not to go out, not to do, and no driving after taking any sedatives, right? Expectorants. Expectorants, they increase the productivity of cough to clear the airway and liquefy the lower respiratory tract secretions, reducing the viscosity of their secretions and making it easier for the patient to cough them up. An example is guaifenesin, also called as Mucinex. Other name is Robitussin. Actions. Enhance the output of respiratory tract fluids by reducing the adhesiveness and surface tension of these liquids, allowing easier movement of less viscous secretions. And then symptomatic relief of respiratory conditions characterized by dry, non-productive cough. Pharmacokinetics will be rapidly absorbed. Metabolism and excretion has not been reported. Now talk about expectorants adverse effects. What are the adverse effects? GI symptoms: headaches, dizziness, mild rash. Prolonged use may result in masking serious underlying disorders. We will always check the history and physical. Allergies, persistent, any asthma, emphysema, which is underlying lung conditions, skin temperature, respirations, and adventitious lung sounds, orientation, and affect. Example is guaifenesin. Symptomatic relief of respiratory conditions characterized by dry, non-productive cough in the presence of mucus in the respiratory tract, right? So how many times do we use Robitussin? Multiple times when we have cough, sneezing, someone's coughing and sneezing and just having mild cold. Okay, let's give them Robitussin, very commonly used medication. Okay. Which of the following is an adverse reaction of topical nasal steroids? Increased nasal drainage, rebound effect, suppression of healing, local ulceration. Suppression of healing. Mucolytics, something that will break that thick mucus. Increase or liquefy respiratory secretions to aid in clearing the airway in high-risk respiratory patients who are coughing up thick, tenacious secretions. Such as examples could be acetylcysteine and also Dornase alpha. Mucolytics, they would work to break down the mucus in order to aid in the high-risk respiratory patient in coughing up thick and tenacious secretions. Indications. What is the indication? Whenever patients have like really thick secretions, they're not able to cough it out. Sometimes even in cystic fibrosis, patients who develop atelectasis, who undergo diagnostic bronchoscopy, post-operative patients, and patients with tracheostomies. Nebulization and direct instillation into the trachea. Sometimes these medications could be directly, like in a liquid form, instilled in the trachea. Cautious. We have to be real cautious if a patients have acute bronchospasm, peptic ulcer, or esophageal varices. Adverse side effects will include GI upset, stomatitis, rhinorrhea, and bronchospasm and rashes. Assess, check. What do we check for? History and physical, allergies, any presence of bronchospasm, peptic ulcers, vital signs, baseline vital signs, and lung sounds. We listen to the lung sounds. Acetylcysteine, or also Mucomyst, other name is Mucomyst. It's a mucolytic adjunctive therapy for abnormal thick secretions, mucus secretions in the bronchial tract. This acetylcysteine is also a reversal agent for Tylenol toxicity, which is acetaminophen toxicity. That is one of the important things to memorize. Then actions is splits link in mucoprotein contains. So in the respiratory mucus secretion. So basically what it does is it breaks that thick secretions and it liquefies it. All right. Adverse effects include nausea, stomatitis, urticaria, bronchospasm, and rhinorrhea. What drug enhances the output of respiratory tract fluid by reducing the adhesiveness and surface tension of fluid, which facilitates the removal of viscous mucus? Guaifenesin, flunitrazolide, acetylcysteine, or dextromorphone. So acetylcysteine is the answer. Okay. So this enhances the output of respiratory tract fluid by reducing the adhesiveness and surface tension of the fluid, facilitating the removal of viscous mucus. So with that, this was just an overview of the upper respiratory tract medications. This is video 1. We are in video 2. I'm going to discuss medications for respiratory tract, for lower respiratory tract. Now, for an example, for patient story example, let's think of a patient is admitted and then they're having coughing, sneezing, and they're having shortness of breath, difficulty breathing. So coughing, sneezing could trigger some asthma effects in the lungs, and it could cause patients to have bronchospasm. And this is very common because we know that a lot of patients will go through upper respiratory tract. How many times we have upper respiratory tract infections. So whenever we have it, so let's say if we have cold and cough, we will just say, okay, let's do steam. Let's take maybe a cough medication, which is Robitussin. We usually will take a cough suppressants because not necessarily on common cold, the secretions are not as thick as compared to patients who have chronic disorders. So think about a condition like that. And those are the medications which we just discussed is for upper respiratory tract infections. So typically guaifenesin, Robitussin. Sometimes we take lozenges to soothe our throat, such as what are those, like Halls, but they are just menthol, just to open, they're just soothers. But on the other hand, medication wise, mostly it is mucolytics, cough suppressants are antitussives, and then some of those medications, decongestants, are the medications which we take for common cold. Okay, so this is for video number 1. Take a 15 minutes break and then watch video 2. Video 2 is going to be medications for lower respiratory tract, and then I'm going to review the PowerPoint from Professor Lee. So those two are in video number 2.